design surveys, end of projects evaluations, longitudinal studies, among other evaluations as a team member, team lead, or co-researcher. Madame Dube, I'm told you are now very well online. We have about 10 to 15 minutes to listen to your abstract. Over to you.
Morning, everyone. I hope you can hear me very well from Zimbabwe. This is my presentation outline. Allow me to skip it. In Zimbabwe, the HIV landscape dating back from 2019 revealed serious challenges, particularly for children and young people living with HIV. With an estimated 1.35 million people living with HIV, the overall prevalence for adults was around 12.9%. Although approximately 86% of HIV positive individuals knew their status, only 62% of children and young people living with HIV accessed antiretroviral therapy, falling short of the optimal target of 90% in 2019. Stigma, poverty, and limited healthcare access hindered ART initiation and retention, with adherence rates among youth at approximately 63% and viral load suppression at just 47%. And further records review at Mpilo Center of Excellence in 2021 revealed not much change from 2019 among the children and young people living with HIV aged 0 to 24 years, where they continued to have poor outcomes and low viral load suppression, with this group facing high rates of defaulting and low return rates to care. These challenges contributed to poor health outcomes, increased morbidity and mortality rates, and hindered progress towards achieving viral load suppression among children and young people living with HIV. So to tackle these challenges, Million Memory Project Zimbabwe, together with the Ministry of Health and Childcare, the National AIDS Council and AIDS Health Foundation implemented an innovative approach which was grounded in the ecological model, and it considered multiple layers of influence on health, from individual behaviors to family dynamics, community support, and institutional structures to complement government efforts. So this holistic approach, which utilized the body system, aimed to address the various factors influencing health outcomes by empowering individuals, strengthening relationships, building community networks, and fostering an environment that was conducive to health-seeking behaviors. Ultimately, this approach would create a comprehensive support system that promotes adherence to ART and enhances health outcomes for children and young people living with HIV. So the primary purpose of the project was to create a nurturing environment for children and young people living with HIV, facilitating better health outcomes and improved treatment adherence. And this project was implemented at Bulawayo Metropolitan Province in Zimbabwe, specifically targeting the Mpilo Center of Excellence. And the target population was children and adolescents living with HIV aged 0 to 24 years. The objectives of the project were to reduce the number of children and young people defaulting on ART, thereby increasing the number of young children and young people living with HIV who were retained and remained in care. It further sought to increase the number of virally suppressed children and young people living with HIV, and further wanted to foster resilience among children and young people living with HIV by enhancing their inter and intra-personal skills. So for the ecological model and the body system, there were various activities that were conducted at individual level, where at first peer development facilitators were trained, and these were aged 17 to 24. There was also defaulter tracing that was done at clinic level just to identify those that had defaulted, and for those that were found, they were assisted with clinical visits ensuring the clinical visits and other activities that were done were buddy sessions that were done on an ongoing basis for 6 months, where the children had an access to play and youth rooms. They further had access to support groups and a youth center, which offered experiential learning activities. Further tracking and viral load case management was conducted among the children, and furthermore, the development facilitators had access to self-care sessions. At relationship level, there were home visits and family therapy sessions that were done, targeting the family members as well as the parents and caregivers of the children living with HIV. Furthermore, parenting skills and interactive meetings were conducted for parents and caregivers. And then for their friends and families that were in school and out of school, there were comprehensive sexuality education and HIV education sessions that were done for their peers. And the main thrust of these sessions were to reduce stigma and discrimination among the peers and ensure that they were supporting the children and adolescents that were living with HIV. At community level, community support activities were also conducted for teachers. It mainly focused on offering psychosocial support, and sessions were done for the teachers to capacitate them to be able to offer that, as well as sensitization of community and religious leaders, where we were acknowledging that these adolescents do not live in a vacuum, but they live within the community, and they're also going to various religious platforms. Trainings and support initiatives were also conducted for healthcare providers, with the main thrust of ensuring that they were offering youth-friendly services. Then at institutional level, we were targeting heads of institutions, where they were also trained on ensuring that their institutions were a safe haven for the children and adolescents living with HIV, as well as ensuring that these institutions were offering youth-friendly services. So the heads of institutions were to come up with action plans that they were going to monitor, and that were also going to assist in ensuring that their spaces were safe, as well as offering youth-friendly services. So from the intervention, there were a couple of lessons that we learned. Retention in care among children and young people living with HIV improved, with a significant increase in proportion of active patients in care from 89% in 2021 to 97% in 2023. Viral load suppression significantly improved from 83% in 2021 to 88% in 2023. And the peer-led interventions were youth-friendly and effective in improving treatment outcomes and viral suppression outcomes among the children and adolescents living with HIV at Mpilo. Children and young people also who took part in the interventions, they reported feeling more motivated to adhere to their medication, attend clinical appointments, as well as disclose their status to others. They further highlighted that they were made to adopt healthier lifestyles. They noted that peer supporters were instrumental in providing emotional support, encouraging medication adherence, and helping them navigate the stigma and discrimination they faced. And the program promoted improved communication and support among families and peers, with participants expressing a greater sense of acceptance and understanding, which was vital for maintaining treatment adherence and mental well-being. As a result, the children and young people living with HIV exhibited enhanced inter and intra-personal skills that led to increased self-efficacy in managing their health. So we also had some key insights from the program, where we saw that the ecological model effectively addressed adherence barriers by considering various levels of influence. We also noticed that involving the community and peers was vital for successful interventions, which fostered a supportive ecosystem. Emotional and psychological support for caregivers is crucial for ensuring continuity of care. And furthermore, regular monitoring of program outcomes allowed for timely adjustment to strategies. Throughout the program, data-driven decision-making ensured that interventions remained responsive to participants' needs, and collaboration with local organizations, community leaders, and healthcare institutions enhanced resource sharing and broadened the program's reach and impact. Furthermore, creating support groups and safe spaces for open discussions about HIV normalizes conversations around the disease and empowers children and young people living with HIV to share their experiences without fear of judgment. So the ecological model has emerged as an effective framework for enhancing health outcomes among children and young people living with HIV, and our results indicate that multifaceted approaches significantly improve adherence to art and promote viral suppression. Ongoing investment in peer-led initiatives and community support is essential for ensuring sustainability. There is also potential to scale this model to other regions and thereby strengthening national HIV response efforts. For us, we have managed to scale it up to UBH as well as other city health facilities within Bulawayo. And we have also done a research in order to explore the determinants of retention in care and viral suppression outcomes among children and adolescents. And this will help us address the root causes of unsuppressed viral loads and attrition in the treatment cascade. In conclusion, the success of the intervention is not solely attributable to one organization. It relies on the collaborative referral pathway, which involved Ministry of Health and Child Care nurses, counselors, mental health professionals, psychologists, and various funding partners. And this was integral and essential for us in achieving 95 treatment targets, and it further aligned with the last World AIDS Day theme of my health, my rights, our responsibility. And we further noticed that utilizing the ecological model and interventions to promote viral suppression among children and young people living with HIV represents a promising strategy for enhancing HIV outcomes and improving the overall well-being of people living with HIV. I was presenting the best practice on behalf of my colleagues, and I would like to acknowledge and thank the Ministry of Health and Child Care, my parent organization, the National AIDS Council of Zimbabwe. Would also want to acknowledge Million Memory Project Zimbabwe for implementing the project, and would further want to acknowledge and thank AIDS Health Care Foundation and TTH Trace for availing funding for the project. I thank you.
Yeah. Thank you, Primrose. Colleagues in the audience, you will agree with me that she has done a very good job, even at a distance. Now let's take a few minutes. If there are questions in the audience about this presentation, to be posed to Primrose very fast. The clock is ticking. Do we have any? Yes, there's one. Oh, yeah. Any other second hand? Oh, okay, there is another hand. Thank you. There is now three. Yeah, those three I think will do for now. Go over, sir.
Great. Thank you very much for a brilliant presentation. I know you said it was a package of different interventions, but I was wondering if any emerged as particularly effective or any emerged as less effective within the package that you pursued.
Thank you. The next question.
Thank you very much, Ms. Primrose, for such a lovely presentation. I'm Dr. Mosa from Eswatini. I'd just like to congratulate you for such a great work, and maybe two reactions. Firstly, I'd like to understand more on the socio-ecological model, particularly the controlling of confounders. Did you control for any confounders in this study, particularly on an analysis? Then secondly, I want to understand on the scalability and recommendations thereof for the rest of Zimbabwean facilities. Thank you.
Thank you very much. is here.
Thank you very much, and congrats on the great work done. So, a number of my questions have been asked already. My first question is, you said because there are ongoing investments, you hope that will help sustain the work. But what if these funding sources are cut? How do we sustain and scale this up? What's your suggestion for sustaining and scaling this awesome intervention up? Again, you mentioned that you've analyzed and found the determinants of viral suppression and retention in this cohort that you are following up. What are these determinants so we can take home and implement in our countries? Thank you very much.
Yeah, those are 5 solid questions. There is one more, such that we take the last one and then we give her time to answer. Over.
Okay, Primrose, thank you very much. I'm a bit familiar with the Zimbabwe, so I just wanted to hear from you if this model is being also implemented in other provinces apart from Bulawayo, and what has been the lessons from there. Thank you.
Okay, so that is from the presenter, yeah? You are asking the presenter. Okay, beyond Bulawayo. Okay, thank you very much. Now over to you, Primrose. Did you hear the questions well?
Yes, I did. I hope I managed to capture all the questions that were asked. So the first question was asking me which of it's sort of a bag of interventions that we were implementing, and the presenter was asking which of these interventions were less effective. So from our implementation, we noticed that we could not leave any of the 4 pillars of the ecological model. Because we noticed that as much as we would want to focus on the individual, there were some other factors that were affecting them in maintaining their viral load suppressed, as well as in retaining them in care. So it meant that we needed to make sure that the whole environment was conducive for the adolescent and the children to come and access services, as well as conducive for them to live within their communities. So none of the 4 pillars we found to be less effective, hence us ensuring that as we're implementing, we are targeting all the 4 pillars of the ecological model. So the other question was asking me whether we did control for confounders. For the program that we were implementing, considering that most of these adolescents that were in children that we were following up to were adolescents that were lost in the process and were not retained in care, and adolescents that had a viral load that was not suppressed. These are the adolescents that our intervention was specifically focusing on. So in some way, we felt that all the 4 pillars or the 4 interventions that we're doing at the different levels, they were effective, in the sense that if we had not implemented these interventions with these adolescents, we had already lost them in care, and also their viral load was not suppressed. Hence, us having to work with them as a group and seeing these changes in them being retained in care, and also seeing their viral load being suppressed, somehow we felt we had controlled for confounding factors. Then in terms of sustainability, in terms of scalability, this program started focusing on Mpilo Center of Excellence, which is just one facility in Bulawayo. But after the results that we saw at Mpilo, we had scaled it up to UBH and other 21 facilities that are run by the City of Health. And we are continuously monitoring and continuously improving the program. And once we are at a stage where we feel the program has been doing well, I think it can then be scaled into other provinces and other facilities. But for now, as a province, in terms of our children who have been initiated on art and in terms of their viral load being suppressed, I think we have seen some tremendous improvements from the 2019 to 2021 and to the last HIV estimates that we did in 2025. We have seen some tremendous improvement around their viral load being suppressed, and we feel the interventions that we are implementing within our facilities, they are doing a very good job in ensuring that we retain them in care as well as have their viral load suppressed. And then for the research that we had said that we are doing, we actually did it and we have managed to analyze the results. And from the results that we analyzed, we noticed that most of the issues that were affecting the adolescents and making them drop out of care were to do with the stigma and discrimination at family level, as well as at community level, or even at institutions, be it at school or be it at the churches that they go to. We found that most of the adolescents that were struggling with being retained into care, or most of them that were struggling with their viral load, adolescents that were living in alternative care or that were living with caregivers who were not their parents. And hence we noticed that by including the family level, the caregivers of those parents within our interventions, it also made them understand the needs of these adolescents that are living with HIV. It also made the extended family, where the children living in alternative care, further made them understand the kind of support that the adolescents needed in order for them to achieve viral load suppression, as well as in order for them to be retained in care. We further also noticed that from the research, the adolescents highlighted that in terms of their school, they would not maybe participate in sporting activities because they didn't want their peers to know that they were taking medication, or at times if they were participating in sports and they were to travel out of home, they would then miss their medication because they also didn't want their teachers and their peers knowing that they were taking art. But through engagements, we noticed that it was very important for the teachers, for the schools, even for the children that the other learners to understand that there are people that are living with HIV within their schools that needed their support. And so these are some of the determinants that we found from the research that we conducted. But if there's anyone who would want to know more on the determinants that we found based on the research that we then further did, they can be free to contact me and we can share notes.
Excellent, excellent. Thank you very much, Primrose. And you have handled the issues in record time. Colleagues, time is running out. I would like to ask to join hands, and we thank Primrose for saving face of this session while online. Thank you very much. A big thanks to you, the audience, for making time to come and listen in. Thank you very much. And then the greatest thanks to the IT team. For the first time, I've not seen you struggling. But I was going away from this ICASA with a very negative whatever about IT, but you have really squared where it matters with me. Thank you very much. Our tradition is to have a photo, Primrose, with the presenter, but since you are not around, I will invite the audience to come and we take the photo moment, and then we enter